Good morning, good afternoon, good evening, everyone. Thank you for joining us today. The Global One Health Initiative webinar is supported by the NIH Fogarty International Center. Our topic for today is surveillance, where we are now, the barriers to implementation and how we may overcome them. And we will be hearing from two guests today, Dr. Alasdair King of Merck Animal Health and Dr. Andrew Gibson from Mission Rabies. Before we start, I would like to briefly introduce our two speakers. Dr. Alasdair King became qualified as a veterinary surgeon from Glasgow University in 1919. After 11 years in mixed practice, he joined Intervac UK as livestock veterinary advisor. Among other roles in the UK, he took responsibility for company pharmacovigilance as a national PV manager and developed the UK focus on transboundary and emerging disease as a government liaison officer. During this time, he was responsible for working on avian influenza vaccine bank and led the company response and vaccine rollout plan for the outbreak of blue tongue serotype 8. He was also responsible for media communication and crisis management at MSD Animal Health. And in 2012, he joined the institutional sales department of MSD Animal Health in Netherlands, being primarily responsible for foot and mouth disease virus. Now the executive director of International Veterinary Health for Merck Animal Health in New Jersey, USA. He has developed the Emergence newsletter, website, and serves as a host for Emergence podcast to provide information on emerging transboundary disease. He worked with a number of government and other organizations on disease control plans and strategies, focus on vaccine accessibility, education, alongside surveillance and monitoring. Dr. King has a long-standing partnership with OSU GOHi, and during his most recent visit to Ohio State University back in March of this year, he gave a talk, and he gave a talk to the College of Veterinary Medicine, among many other activities. Our second speaker is Dr. Andrew Gibson, a researcher and epidemiology manager at the Mission Rabies. He received his degree in veterinary medicine from Royal Veterinary College in London in 2010. After both working and doing research on charity veterinary practice in UK, he began working for Mission Rabies during in 2013 launch campaign in India. He has a previous experience using smartphone technology in an epidemiology context in Zanzibar and Tanzania, transferred to the work on rabies. He has tasked with developing a smartphone app to overcome challenges faced during mass dog vaccination campaign and rabies surveillance. Now the app has been used to record nearly 2 million dog vaccination on project worldwide and has been demonstrated to not only improve coordination of vaccination campaign, but also to double the vaccination coverage achieved. In addition to continue innovating in software, Dr. Gibson work focused on project evaluation, improving the efficacy and effectiveness of field operation for rabies control and dog population management. So without any ado, I will go ahead and hand it over to Dr. King. You may start screen sharing anytime.
Thank you, Zalalam. I'm hoping for everyone that my voice can make it through this presentation. I have had some major throat problems during the last week, which is generally left over from COVID last year. Not good when you run podcasts to have throat problems, but hopefully you can now all see my screen. I will talk to you first about what we see as some of the barriers to surveillance and the implementation in the animal world, or how we see the future. This is going to be a very general approach, talking about what's happening at the moment and this high level view. I'm not going to give you a whole heap of answers, I'm afraid, more problems rather than answers, but we'll do that. And then Andy is going to talk to you much more specifically about his experiences really on the ground with surveillance and how that fits into a national vaccination campaign or regional vaccination campaign to actually get to eradication of a disease and why it's important. So we're looking at what about surveillance in general, and then a very specific example when I go over to Andy. So when we think about surveillance, the first question I've really got for you is, do you think that the current processes we have actually encourage surveillance? is this something globally that we managed to do well and we're successful with in a way that makes sense to actually help us control diseases? Bearing in mind, there are only 2 diseases in the world that we've ever eradicated, one human, smallpox, and one that is animal, rinderpest. We've only managed to eradicate 2 diseases. How come, with all of the science and knowledge we've got, we've only managed to do that? Yet we understand the diseases, or we think we understand diseases in a large way. So why aren't we managing to get rid of them? Is it because our surveillance isn't good enough that we don't really know what's happening in the world? When we look at animal health systems and animal diseases, the OIE, the World Organization for Animal Health, has a reporting system. WAHIS, the World Animal Health Information System. This is a really good system. So governments, when they get notifiable diseases, report into this system. Everything gets put into one place. You can go on there, you can draw off information. There's all kinds of analytics. It's amazing what's on there. The list for over years and years, you can compare what's been going on. You think you can see what's happening. So if we've got this system and governments are feeding into it, we should know everything, shouldn't we? Our website, Emergence, covers a number of things to do with diseases, but one of the things it does is it draws the outbreaks that are coming into WAHIS, getting reported, it draws off on those and actually puts those into somewhere where you can go onto the site and you can look at the page, look at a region, and you can see how many diseases are occurring or how many outbreaks over a period of time. So these are 2 screenshots I've got. The upper one is a screenshot covering Africa and the lower one is Europe. And this is covering a 6-month period, the same 6-month period. And you can see how many outbreaks there are, how many affected countries, and how many affected species. Now, the way it's set up, just because of the algorithms that are used, 54 countries feed into the Africa region and 55 feed into the Europe system. This is over the same 6 months. Now, so happens Africa has 54 countries feeding in and Europe has 55. So what's strange with these 2 screenshots? Look at those numbers. In Africa, we have 36 total reported outbreaks. Yet in Europe, we have 269 reported outbreaks. Do we truly believe that Europe has a lot more disease outbreaks than Africa? Is this really reflecting what is going on? The diseases that we're covering, epizootic hemorrhagic disease, avian influenza, foot and mouth disease, pesty to petty ruminant, anthrax is in there. There's a whole heap. We haven't got everything, but we're picking up a lot of the different diseases. Do we truly think that Europe has a bigger problem than Africa when we know that a lot of these diseases originate in Africa and spread out from Africa? The answer is, of course, not. So our surveillance isn't working. We're not getting the right numbers coming in. Now, people often talk about the hotspots. They focus on, this is where we see disease happening, the hotspots. We can see these little focuses and, this bit of the world here, and we can go to Myanmar and we can see a bit here, and we can go to Vietnam, we can see here, and we can see this, and it's great. Right, we can focus on these hotspots. I really don't mind about hotspots, because if we've got hotspots, our surveillance is working. We know where the disease is. We know it's there. We can do something about it. I'm much more concerned, the big picture of the cold spots. Why have we only got 36 reported outbreaks in Africa if we've got 269 reported in Europe? Those cold spots are the danger points. And this is why we need to look at surveillance and think about it, because that's where things are going to come from. Why is surveillance important? Why am I passionate about this? And something that in so many meetings with the WHO and the OIE, I keep raising and talking about these cold spots and hammering home on it. If you listen to the podcast, I'll talk about it. I do go on about it too much, but I truly believe it's important. First off, simply predicting new diseases And the last 2 years, 3 years, is a really good example. We've had the COVID outbreak. We've had this problem that's affected the whole world, came from animals, gone into humans, seemed to come from almost nowhere. Our surveillance wasn't good enough to pick up a new disease appearing and get to it at a point where we could actually do something about it and get it under control. So that's one reason why surveillance is important. Then simply understanding disease epidemiology. If you don't know where the diseases are occurring, how do you understand what they are and how they're spreading? We could look at blue tongue disease for cattle and sheep, typically in Southern Europe and in Africa, doesn't usually go much further out. But back in 2007, 2008, don't quote me on that date, that year, blue tongue serotype 8 suddenly appeared in Northern Europe. How did that happen? Why did it suddenly occur there? If we don't have the surveillance to see the disease, then we can't understand how it's transmitting. When we look at lumpy skin disease, a cattle disease, which again, from Africa, appeared in Southern Europe a few years ago, and suddenly started moving around, and now it's in Asia. So this disease, which for a very long time was localized, is suddenly spreading. And we know that some of that is going to be down to global warming and changes in the environment and things like that. And certainly some of it is down to travel as well, that you can now move much further, much quicker. So disease gets this opportunity to move. But one of the outbreaks of lumpy skin disease, we saw one case in Greece, and then the next case occurred 5,000 miles away. How on earth does a disease suddenly jump 5,000 miles? If we've not got the surveillance and we can't see how the disease is transmitting, we can't understand how to control it because we don't know the epidemiology. If we don't have proper surveillance, we can't identify the risks that are coming. We can't see where the areas are where we can actually get disease arising. We can't get on top of it. We can't understand it. And then we can't minimize the impact when it starts spreading. If we don't know how it's being spread, we can't stop it being spread. So surveillance is important for all of these areas and all of these reasons. And ultimately, that leads us to eradication. We're only going to eradicate if we can do proper surveillance and understand where the diseases are. So surveillance is incredibly important for us to take on. There are a lot of barriers, however, and this is why we don't have good surveillance. The barriers are multitudinal, they're cross-functional, they've got everything that's going on. They occur at government levels, at political levels, at economic levels, social levels, and individual levels, and health systems, and local levels. And I'll explain some of that. If we look at political, when we talk about some of these diseases, they are become part of trade barriers. If you've got a certain disease, then you can't trade with countries that are free. You can't open up your borders. You can't export. And in some cases, you can't import. That's a really big barrier to people wanting to report what is going on. Then at a government level, it can be a case of whether people are going to come and even visit your country. So we talk about rabies, and Andy's going to talk about rabies a bit more. If you're a country that relies a lot on tourists and the tourist industry, do you want to be talking about having a rabies problem? Because that could stop people actually coming and visiting you. So you don't want to talk about these things. So there's these big global pictures of why you wouldn't want to actually be reporting at that very high level. Then you can go all the way down to individual and local levels and seeing what happens there. If you're a farmer and you've got 5 cows, and that's your livelihood, then are you going to want to draw attention to your 5 cows if you think they might have something like foot and mouth disease, if what you know is going to happen, if it's confirmed, someone's going to come on your farm and going to kill those 5 cows? They're going to slaughter them. And that's your livelihood gone, and you're not going to get any compensation back. And that's actually your food for the future. And that's your livelihood, and just purely your chance of surviving and your family surviving for the next year. So of course, you're not going to report these things. You're going to keep it quiet. You're not going to want people to know. And you've got the pressure from your village that if you have a problem, then everyone else is going to have a problem as well. And then you're not going to want to be seen, to be talked to. And that gives you a really big social and local problem. Health systems are definitely a major problem. Surveillance and disease control goes hand in hand with health systems. And if we don't have a strong enough health infrastructure, then we're not going to see what is going on. And by health systems, I'm not talking about just doctors and vets. It's everything that goes around that. It's the paraprofessionals that work in those fields as well, the people who are able to give advice, the nutritionists, the other areas where you're going to get healthcare coming in, looking at what's going on. All of those things come together to give you a strong health system. And what we tend to focus on is we focus very strongly on, well, the vets and the doctors and getting those up and improved. But if you don't have everything else underneath, you're still not going to make a big enough difference. If we talk about foot and mouth disease and countries that are free of foot and mouth disease, if you get that disease coming in, it's devastating to your livestock, because it's going to go through them and it's going to cause all kinds of problems. It's going to reduce your milk yields. It's going to kill a lot of animals. It's going to have impacts on tourism. When we look at the UK outbreak back in 2001, that was multi-billion dollar damage to the country, and the UK still hasn't recovered fully from that. So it's really damaging for a disease to come in. But if you've already got the disease, then that damage is already done. And you don't see that much of an improvement just if we just treat foot and mouth disease. If you don't have a good health system infrastructure, if we only try and treat one problem, you're not going to see that much of an improvement. So we need to raise the overall health in order to start making these things important and start looking at diseases that we want to control. So if we look at that, how do we start to overcome the barriers? What do we need to do that is going to move us from where we are now to a position where we understand properly and we're able to see what's going on? Improving training is really important. And again, I say not just to vets and to doctors, but paraprofessionals, people who are in constant contact, going into villages, working with people, knowing the local communities. Often where we haven't got strong health systems and strong infrastructure, then they're not seeing vets or doctors that often. And it's local paraprofessionals who are the ones who are giving advice. And we've tended to ignore those quite often with a lot of the training that's been done in the past. That is certainly changing. We're part of a project at the moment working with the EU FMD, which is part of the Food and Agriculture Organization, and Health for Animals, which is an overarching body looking that speaks for the pharmaceutical industry, and Gates Foundation involved, and a few other people, where we're looking at how we can bring training to paraprofessionals. And that's going to be really important for how it changes how people do look at things and how they're able to talk to people. We're also looking at how we can use apps on phones to bring people information on disease, real-time information, so they can see what's going on and start feeding that back. Understanding local needs is also really important. In a lot of these cases, what's happening is people from the Western world are coming in thinking they know all the answers and thinking, well, we know we managed to eradicate this disease in the UK or in Europe or in America. We'll just bring that knowledge over. But the situations are different, the cultures are different, how the animals are interacting with people is different. All of these things is really, it's not easy to take something from one country and just take it across. But in the past, that's what we've tried to do. So it's much more important that we sit down and spend time talking with local villages, bringing people together to actually see what is going on. We have a project in Tanzania where working with the University of Glasgow, but that has been very much based on what is the local situation. And what we've been doing is bringing together the farmers, the village elders, the local, regional vets and the government to all sit around the table in workshops and really understand the drivers, rather than coming in and just telling people we need to control a certain disease. We're actually understanding what their needs are. I've already talked about engaging paraprofessionals and building animal health infrastructure. Those two things are really essential. If we don't do that, we're not going to get anywhere. And then providing value. Why do you want to report something? If you don't have a reason to, then you're not going to. And as I put up the barriers that stop a lot of people currently actually reporting things, we need to turn that around so there's actually a value to it. By reporting disease, then you improve we bring in people who are actually able to help and make your animals healthy and improve the overall health of them, rather than we're going to come in and just slaughter everything. And then the other thing is innovating. What we've done so far hasn't worked. We need to innovate and we need to think about new ways of trying surveillance. And that brings us to technology. It's a really exciting world at the moment when we look at the technology and how we're able to start moving that into the future and what we're able to do. So far, we haven't got everything that we need, but we can see where we're going. The first is animal identification. I think Andy will probably talk about that a little bit, but when you look at surveillance, if we don't even know how many animals are around, then how do we have any surveillance that is meaningful? So the first bit is getting to the point of understanding what animals we've got. And that can be done in a number of different ways. Ear tags are really easy. Put an ear tag on and then you've got a number on there and you can go and read it. But pure visual ear tags have problems. They fall out, that's one of them. But you have to be able to read the number, you have to be able to see what's going there, you have to have people who transcribe it properly, all of those issues. We're moving much more into electronic identification. And that can be done in a number of different ways. You can use microchips, small little chips that you put into the animal, into its ear or under the skin, which when you run a reader over it, or they run through a race, so all the area where you take animals in to treat them, there is actually a reader that can pick up what that individual animal is and identify it. That's not possible with all animals. We've also got things that are being used now, like facial recognition, being very useful for identifying stray dogs, where you can use camera pictures and you can use a computer to actually recognize by face those animals. Now you put that in with something like drone technology, where you can have drones flying over an area, they can see the animals, they can get the picture, they can identify them. Then we can cover very large areas in a relatively short space of time to actually start really identifying which animals we've got and how many there are. Another option is managing to link animals to medications, knowing which animals have had vaccines, which ones have been protected against these diseases. That's also very important for us with surveillance, because we need to understand how the disease is spreading in communities, and knowing what's protected and what isn't is part of that. So what we're able to do now is we're moving to a point where you can have vaccination equipment which manages to read the ID on the animal if it's got electronic ID, but it's also able to read the barcode on the vaccine. So now you've got something that can actually link together, this animal had this vaccine and this batch was used. Very important to be able to identify batches, because if a batch hasn't been looked after properly, hasn't been taken care of, and you've got a batch problem, then you're able to pick it up very quickly. So that becomes something that we're really able to start exploring now. Once you start getting to that level, you can start looking at your population management. How do you actually understand these group of animals, how they're moving, and you can build that into proper vaccination programs. Part of what I've done for the company for many years, I was responsible for pharmacovigilance in the UK. So looking at reports of products that don't seem to have done what was expected. And especially when you look at vaccines, people have vaccinated and then you still get outbreaks. We see that at the moment with COVID, where people talk about it. Why does that happen? It's usually not because there is a problem with the vaccine. It's usually to do with problems with the vaccination program. And understanding that comes down to proper population management, understanding how you've got your animals actually moving together. Then we're able to start tracking animal movement much, much better. So when you look at imports and exports, if we're able to track animals and we're able to identify them and able to understand what they've had, what medications they've had, then suddenly the barriers to trade become a lot less important, because now we know what animals are doing, we're able to see what they're doing, and we know if they've had vaccinations, we know if they're protected, and we can start building that into what's happening. And if we start doing that, then we allow more trade, that allows more money to flow. And certainly in countries which, third world countries which are struggling at the moment, the first step to getting out of those poverty traps is to do with agriculture. So if we improve our animal movement, then that is going to allow that to help. So that's part of building in that technology and surveillance. And then the last one is artificial intelligence algorithms. These are really interesting. It's been done with avian influenza, or not avian influenza, human influenza already. What we can start doing, this is very, very clever, but you can start using artificial intelligence algorithms to track things like social media. And if you program in certain words for them to look for, then they are able to key up if there is actually a increase in those words being used. So you can get very early identification of disease spread without anyone needing to actually actively report it. So what we see is people may not be willing to actually go to their doctor or to their vet. They may not want to report something, but what they will do is on social media, they will say that they're feeling grotty, that they've got a high temperature, or that they've got bad eyes, or whatever you want to pick up as those key words. They'll put that into social media for their friends to know. And again, you can look at social media over the last couple of years and you can see how many people talk about COVID and when they've got signs of COVID and what they've had. Now, if you start looking for that, you can start seeing this increase in traffic of these words, excuse me. And you can actually then start to pick up very early on when you've got disease outbreaks. So we're seeing that actually happening. As I say, it's worked with human influenza. It's actually been seen successful. That's really exciting because it's taking away the need for people to actively report. Why is this even important as a One Health perspective? How does it fit in? What do we need to do? I said why surveillance is important, why we need to do it, but how does that fit into this One Health perspective? Awareness of these diseases is important, and especially the zoonotic diseases. It's important for vets to be aware of human diseases, and it's important for doctors to be aware of animal diseases, because that way we're able to start picking things up. I remember very early on in my career as a vet, when I was still in practice, I was down in Devon, which is the bottom of the UK, very rural kind of area. And a mother came in with her dog and her son, a young teenager. And they came in and they put the dog on the table and before they even asked me about the dog, I looked at the son and I said, "How long has your son had ringworm?" And the mother looked at me and said, "What do you mean?" I said, "Well, he's got these little marks on his skin. That's ringworm. It's a fungal infection." And she said, "I've been going to the doctor for ages and he didn't know what was going on." Okay, this is ringworm, and now let's look at the dog. And yes, there's ringworm lesions on the dog as well. So the dog they're passing it back and forth between each other. But because there wasn't awareness of this disease, it hadn't been picked up on the human health side. If we know these diseases and we're aware of them and we think about them, then we're more likely to pick these things up and help each other. And that's where coming to discussing is really important. We sit around tables together, we have group meetings, which are involving vets and doctors and paraprofessionals, all sitting around a monthly meeting, getting together and just talking about some of the diseases that you're seeing and picking up some of the trends is going to be really helpful for actually improving that surveillance, because we start raising that whole awareness and knowing what's going on. And it used to be when I trained, so going back much further than I like to think, but when I trained, then we were told, if you hear hoofbeats, think horses, not zebras. You think about the common things. The world's changed since then. And all of those reasons I mentioned before of why things can spread and what we're seeing, suddenly you have to start thinking about the diseases that you didn't need to be aware of. You need to really be much stronger in your overall knowledge. And that then brings us to the reporting. If things are seen, they need to be reported. And that's really important, getting over the worries and the concerns of why we're going to report and making it a positive experience. And if on both the human health side and the animal health side, we're able to get reporting done in a proper way, and we stop worrying about hot spots and cold spots, actually instead we understand where the disease is, how it's spreading, the epidemiology. By improving that surveillance, then we're going to improve the future for all of us on disease control, and that's what's going to lead us to a sustainable future. So I'm going to leave it at that, and I will pass over to Andy, who will talk to you about much more specific examples. But if you want to go to our website or listen to the podcast where we talk about transboundary emerging diseases, then those are both possible to go to. Thank you very much for listening. I will pass over. Go, Andy.
Thank you, Alasdair. Hopefully my screen is visible on the Mission Rabies logo.
Yep, I can see it.
Fantastic. Thank you, Alasdair, for that wide lens view of the importance of surveillance. I'm going to now dive into the issue of rabies specifically and zoom right into the field level. I work for an organisation, a charity called Mission Rabies, and for the past decade, we've been focused on this single disease of rabies and trying to make inroads and make ours the generation that really makes a difference to this neglected disease. Rabies is particularly interesting from a One Health perspective because it really demonstrates the importance of One Health in action, and hopefully this presentation will make that really clear. So the purpose of Mission Rabies is to develop effective approaches to rabies elimination and to support others to achieve their own successes. Over the coming years, we're working towards the 2030 global goal for human rabies elimination of canine transmitted rabies. And we can see that rabies is not a highly transmissible disease. It's easy to eliminate as compared to many of the other diseases that are out there. And so we can make huge progress if focus and priority is given to this disease in particular. We run our own pilot campaigns in partnership with local organisations and governments around the world. Our two largest and longest running permanent campaigns are in Blantyre in the south of Malawi and in Goa State in India. And both of these sites run 100,000 dog vaccination campaigns every year. We then also have smaller pilot project sites which run kind of 2-week campaigns to gather data and provide understanding and experience to local organisations. So the purpose of these pilot campaigns is really to evaluate the methods that currently exist and to innovate and develop tools and solutions to overcome the current challenges. We then also remotely support other organisations and provide technical support at sites around the world, particularly working with governments to enhance their campaigns, to improve their planning, their monitoring and evaluation of their programmes, and supporting them with tools to improve implementation. So we're really trying to maximise the impact of these other organisations and their own efforts and provide training tools, technical support. It's all well and good to put points on a map and talk about projects, but all of these projects come down to individual people. And from our experience in rabies control, it's individual people that make a difference. We need more veterinarians, more medics, more epidemiologists, more government policymakers to make rabies their priority over the coming years. And so all of these projects have been built because of the individuals that are involved. People really do make a difference and can achieve great things. Over the last couple of years, we've been working with MSD Animal Health and the CDC under a collaboration called the International Rabies Task Force, really to expand our reach and improve our support that can be offered to remote governments and organisations. So when it comes to rabies surveillance, an important thing to emphasise is that timely response is absolutely critical. We've got a very narrow window of time to investigate a suspect rabid animal before it dies. Certainly less than 2 weeks, so within 14 days, often within the first 3 days, the majority of dogs die of rabies. And in that infectious period, they're passing the virus on to people, dogs, and livestock. And so having a timely response to reports of suspect rabid animals is absolutely crucial in our surveillance. Alasdair mentioned about these community health workers, and it's also true for rabies. We've started to use the term community one health officers. So they're not just looking at human or animal disease. These officers are responsible for bridging that divide between the human and animal health sectors. And these community one health officers provide an absolutely life-saving service and make a meaningful difference to disease control at the same time. So by identifying, assessing, and removing these rabid dogs early in their disease process, we can prevent that onward transmission to other dogs and people. From our experience of developing rabies surveillance programs really from scratch on the ground, in its simplest form, it consists of 3 basic components. There needs to be an effective reporting system, and we've seen great success of establishing state or district level phone numbers, central hotlines that the public or the human medical sector, anyone, the police, anyone in society can report a suspect rabid dog to this central number, and from there it can be screened and an immediate response can be coordinated. From there, we need to establish infrastructure and mechanisms to enable a response to reports of suspect cases. And finally, we need to have the infrastructure and ability to get a laboratory diagnosis. We've also found great use for these lateral flow assays or lateral flow devices, which are not currently an OIE approved diagnostic test for rabies, but they certainly provide a useful screening tool at the field level. But then it's essential that we create the mechanisms to get a confirmed laboratory diagnosis by OIE recognised diagnostic tests. I'm going to now talk about integrated bite case management, which has been demonstrated as a cost-effective process for establishing this One Health approach to rabies surveillance. So not to be confused with ICBM or intercontinental ballistic missiles, it's IBCM for integrated bite case management. When it comes to IBCM, we have 2 main compartments. We've got the community, in which people live alongside dogs, and this is largely overseen from a surveillance perspective from the veterinary sector, whose priorities are to remove rabid animals from communities and to achieve a diagnosis to support and guide ongoing control efforts. The other compartment is health centres, where people who have been bitten by dogs are presenting for treatment, which is obviously overseen by the medical sector, whose priority is to prevent human rabies deaths through the provision of PP, post-exposure prophylaxis. and ideally to prioritise PEP resources to those at greatest risk of rabies exposure. So we're just going to go through a couple of scenarios here now to illustrate the importance of that One Health approach. We've got people living alongside dogs in communities, and dogs are biting people for all sorts of reasons all the time. Bites from rabid dogs actually represent a very small proportion of all dog bites occurring. In the US, it's estimated that 3% of the population are bitten by a dog every year. In Haiti, it was around 1%. In GOHi, it's around 1%. So it's generally between 1% and 5% of the population are being bitten by dogs throughout the year. But only less than 1% of those bites are due to rabid dogs. And so very few of all dog bites that are presenting to clinics are from rabid dogs. But the health sector is obviously immunizing people, vaccinating people against rabies, and providing post-exposure prophylaxis to those people who are presenting with dog bites. Let's rerun that picture, but from a perspective of knowing what the true rabies incidence was. So in this example, we can imagine that these two dogs have actually got rabies and are shedding the virus at the time of the bite. All the other dogs have bitten for other reasons. They've been chased, or they're puppies, or whatever. They don't have rabies. So let's rerun that scenario. All the people are bitten again. They all present to hospital. And in the status quo, the PEP is administered indiscriminately. So it's on a first come, first served basis. And vaccine shortages are frequently seen across the world in rabies endemic settings. So often people present to hospital with a dog bite, but there isn't any vaccine available because it's been used up from people that are just presenting otherwise. And so this is one of the main benefits of IBCM. If we look at this surveillance picture now from a human perspective only, so as if there's no interaction or no connection with what's going on in the community. We've got this child here has died from rabies because there was no vaccine available due to the indiscriminate use of PEP. We've got these children in the community that were also exposed to rabies but didn't present to hospital for vaccination, so they've now died of rabies. This person here isn't aware of the true risk that is posed to them from having been exposed to the virus, and so it's possible they may not complete their course and are also at risk of developing rabies. And these dogs are continuing to bite people and other dogs in the community. We haven't done anything to halt the transmission of the disease. And finally, we have no oversight of the true burden of rabies in the community. We have no idea of the canine rabies burden. And so if we're only approaching rabies from a human surveillance perspective and human post-exposure prophylaxis, we're missing out a huge part of the picture. If we flip things around and look at this only from a veterinary perspective, so veterinary officers going into communities and looking into these dogs that have been reported as suspect of rabies, that veterinary officer is going to go out and find these dogs, but they're not going to see dogs that haven't been reported, even though they've bitten people that have been to hospital. We're also not going to do anything to raise awareness or make these people aware of the risk of rabies without this One Health approach. So finally, let's run things one more time, but with this integrated bite case management approach. So everyone's bitten again. At this stage, we don't know which dogs are rabid. Everyone, a proportion of people present to hospital, and our IBCM officer, our community One Health officer, is informed that these people have been exposed to dog bite, and they need to go into the community and investigate these dogs. As a result of their investigation, going out and assessing those dogs, they get a diagnosis of rabies where there is one, and they can rule out rabies when the dogs are still alive and survive a quarantine period. So from their investigation, we identify these dogs as rabid, and we can inform the hospital that these people have been exposed to a confirmed rabid dog. And so PEP is prioritized towards those people, and they're counselled to ensure they complete the course of PEP. Through their investigation in the community, they also identify other people who have been bitten but haven't yet presented to hospital. And these community One Health officers then counsel those people and explain to them that you must go and get this PEP treatment, and therefore the remaining PEP is prioritized towards these individuals, and therefore their life is saved from rabies as well. So this integrated approach has a huge number of benefits, both to saving human life, but also providing essential data on canine rabies burden. And it all sits within this role, the Community One Health Officer, someone who's responsible for investigating rabies cases, who's trained and can conduct these investigations. We're doing work to also improve awareness for the WHO definitions for clinical diagnosis of rabies. So using this ALPHA acronym, where a dog that is showing acute signs of abnormal aggression, lethargy, paralysis, hypersalivation, or abnormal vocalization should all be considered as suspect rabid. And this is also relevant for parts of the world that aren't familiar with rabies. Rabies doesn't always look like what we'd expect of a dog that's foaming at the mouth. They can just be showing signs of lethargy. They can be showing signs of paralysis. And so it's really important that paraprofessionals and veterinarians are familiar with the potential signs of rabies and what constitutes a suspect rabid dog. Following on from these clinical signs, we can then define what constitutes a suspect rabid animal. So that's a dog that's showing any of these signs. A probable rabies case is a dog that has been in contact with a suspect animal and is also showing signs, or a dog that's killed, dies, or disappears within 5 days of showing any of these signs. Confirmed cases are animals that have got a positive laboratory test, such as DFA or PCR, and non-cases are animals that have survived for 14 days after the onset of signs, because in rabies, we know that signs progress and animals die within a 14-day period, and animals that have been tested negative on laboratory diagnostic tests. We've developed this video, which is on YouTube and provides footage from our project sites of the signs of rabies. It's 10 minutes. You can find it by searching for Master of Deception, Signs of Rabies in Dogs. And it goes through the unexpected and unfamiliar signs of rabies in dogs. So I encourage everyone to visit that and get familiar with what rabies looks like. So these Community One Health Officers are the core of rabies surveillance, and similar was found in other disease control programs, particularly Rinderpest. The community officers were absolutely critical in getting to know those communities, meeting with farmers, understanding what's normal, what's not normal, where the disease is circulating. But it's not easy, particularly in a disease like rabies, where investigations can be drawn out over several days or even weeks for animals undergoing quarantine. And so keeping all of this information centralized and making it available to superiors and to supervisors at the district level, for example, and also tracking multiple cases at any one time can be really, really difficult when you're using paper records. Things fall through the cracks and it's very hard to keep up with it. So one of the innovations we've been working on is a smartphone app called React that brings all of this information into one smartphone application and provides prompts and notifications to remind the officer when the next task is due and to provide them with a framework on which to conduct these investigations. The React app, it stands for Rabies Exposure Assessment and Contact Tracing App, but React is obviously a lot easier. And this was developed through Innovation Fund Challenge funding in partnership with the CDC. So the surveillance component of the app has been in place for over 3 years now and has been used all over the world. It's used for rabies surveillance, obviously, for the longitudinal tracking of cases and managing cases throughout that investigation. Alongside that is another app which is used specifically to track vaccination activities, for conducting population surveys, even tracking population management, surgical sterilization activities, and education work. So this sister app to the React app is really an event tracker, and it also coordinates the spatial management of vaccination teams. I'm going to focus in just on the React app itself. Both are available on Android and iOS, so are widely available and have been translated into a number of languages also. Just briefly to give an overview of the structure of the system, the app integrates with a backend server and uploads data as and when connection is available. So data can be entered offline, and then when connection becomes available, the data is synchronized to a cloud-based server where it can be accessed by an administrator or supervisor of the project. So we have field users working on the ground, offline, entering data, conducting case investigations, and then we've got administrators either at the national level or at the district level accessing that data and providing guidance. We've also built a bite register component, which is a web-based application for use in bite clinics itself. So this also helps with the integration between human and animal health sectors by capturing that bite data to then instigate an investigation where there is a high risk of rabies in the field. The flow of an investigation is really broken down into these 5 sections. So we have an initial notification followed by an assessment either over the phone or in person. Some cases will then undergo quarantine, laboratory results are reported, and finally the outcome of the case is reported back to everyone that was involved, from people that have been exposed to the person that reported the suspect dog, owners of animals that have been exposed as well. So it's important that we disseminate the results back to everybody that's been involved in that case. So the event notification is this initial notification from any sector of society. We then have the rabies assessment, which is done by the Community One Health officer. Quarantine, where we check in on that animal over a period of 10 or 14 days to see if it's disappeared or died or is still healthy. And then reporting back the laboratory results following sample submission, and finally reporting back to the individuals involved. So the app itself has been designed to be as intuitive as possible, and really to make this IBCM protocol easy to implement on the ground remotely. So we've got the event notification can be accessed through this section of the app. Then these sections cover the assessment component. We've got a form for quarantine updates here. The results are reported through the results section, and finally a reporting section. So this screen kind of unfolds and grows as an investigation progresses, and really provides that structure to help guide the officer through the case. Here's a quick snippet of what the app looks like in action. We've got grouping of various forms, so it's easy to access cases that require lab results to be reported. We can go into the case and bring up the details of that particular case, and then we can report, for example, here, the results of that case in easy to use forms that are dynamic. They update as you enter data and provide guidance to the user based on what they put in. So now I'm just briefly going to give some examples from our fieldwork, from our projects, to illustrate the real benefit of enhancing rabies surveillance. Starting off in Bangalore, so this is a project that we've been working with the local government and local NGOs to enhance existing surveillance activities. We began using the RAC system and actively investigating suspect cases in 2020. And following that, we've seen a significant increase in the number of cases that have been both tested and diagnosed positive for rabies. It's important to acknowledge Dr. Islaw and his laboratory at the Bangalore Veterinary College, who are doing the testing in Bangalore City. So here in 2020, we can not only see the true burden of disease, or a much more accurate burden of rabies in the city, but from that app data, we also get the GPS location of all those dogs. So we can see the distribution of rabies. And as Alasdair said, really trying to avoid those cold spots to get a true perspective on where the disease is circulating. And the same is true for 2020 as well. And so then this becomes the foundation of our control efforts, where we can then monitor the impact of any vaccination that's done in the dog population, without which we're just vaccinating dogs and we have no idea if the burden of disease is going up or down. Jumping over briefly to Haiti, exactly the same thing was seen from the CDC and MANDA data. So we can see that from the start of their IBCM approach in 2013, they saw a significant increase in the number of cases submitted for testing and an increase in the proportion of positives. Something we've seen in all of our project sites is during the early phases, a high proportion of cases positive, but then as we increase testing and improve the surveillance, we get more negatives to really try and capture the true burden of disease. Through the app technology, we're also providing monthly summary reports of the data at a national level. and also providing maps that discreetly and kind of clearly summarize what that complex data set is telling us, and providing maps of rabies risk and where we need to intensify surveillance efforts. And so all of this data is really stimulating momentum and political motivation to take up the issue of rabies. Once we can see how much rabies is there, there's clear reason to develop control activities and establish dog vaccination campaigns. The app has been absolutely crucial for supporting implementation. It's all well and good in having a system, but if it's complex and difficult to adopt, it's going to be very difficult to scale that. And so our project in Vietnam is working in a few pilot sites, and from that data coming into the app, it's readily centralized and accessible by the program managers, and they can review progress and provide guidance and feedback to field operatives based on the data they're putting in. Using paper-based records, it can take months to get that data to a district level, and through the aggregation process, a lot of the detail is lost. So we can create kind of schematics like this that show the total number of events that were notified in the app. We can then break down at the assessment stage what the outcome was, so what proportion of those cases were dead on arrival, what proportion were euthanized, what proportion underwent quarantine, and so on, and also the proportion of cases that weren't followed up. Of those, we can see the outcome at quarantine. So obviously the ones that were dead on arrival didn't undergo quarantine, but of those quarantined animals, which ones passed and which ones were ongoing. And then finally, we can see what proportion of animals were not tested positive and negative. So it gives us this fantastic insight into ongoing case investigations, and field managers can then identify issues and provide guidance to their field operatives. Finally, just to illustrate from our project in Goa, which has been running for the last 8 years in partnership with the Goa government, the surveillance data there has been absolutely crucial to documenting and monitoring the impact of our statewide dog vaccination activities. So the app that I mentioned earlier for dog vaccination records has been used year on year for the past 8 years to record the GPS location of every dog that's vaccinated. And these maps show each year the GPS locations of dogs vaccinated around this state. And we can see that they've been working throughout the state year on year for the past 4 years. But what the surveillance data shows us is the distribution of cases in relation to that vaccination effort. During the early stages of the campaign, we were seeing rabies throughout the state. So the blobs here, the circles, are showing positive canine rabies cases. But as the years go by and our vaccination efforts intensified and scaled up, we can see those cases diminishing until all the way through to 2021. And we haven't actually had a case for the past 9 months or so. And the cases that we saw before that were all restricted to the North Border region. So we're currently intensifying our surveillance efforts in this area, intensifying vaccination, and we're establishing viral sequencing capacity to really understand where these cases are coming from. We expect that they're coming from over the border from endemic regions neighbouring Goa. But obviously without this data, we're blind to how we can effectively apply our resources to control the disease. That vaccination data and surveillance data also really helped us to see the impact of COVID-19. So this was human COVID-19 deaths in Goa during 2021. And we can overlay the weekly dog vaccinations during this period. And we can see that where the lockdowns hit and we had to stop dog vaccination during this period. We can also then overlay the number of canine rabies tested and positive cases through this period, and the impact of those lockdowns potentially causing an increase in rabies transmission over that time. So hopefully that gives a helpful insight from our experiences of rabies control from the field. As I say, it's all grounded in the people that are giving their effort, their time to rabies control. And we need to increase the number of vets that are dedicated and giving their careers to this problem. There are too many people to thank, but a huge number that are involved in making this work possible. So thank you to them. If you're interested to hear more or interested in using any of the tools that I've described today, please do get in touch on email. Thank you very much.
Thank you very much, Bose. To our participants, please submit your question through the Q&A chat, or you can also raise your hands. I can let you in, have the mic to ask the questions. But both Dr. King and Dr. Gibson, thank you very much for 360 overview of the surveillance, the barriers to implementation, and even practical application in case of rabies. I see Dr. Getnet has raised his hands. Dr. Getnet, you may go and ask your questions.
Thank you so much, Dr. Zelalem, and wonderful presentation indeed, Dr. Gibson and Dr. King. That was very enriching, very timely. So one question for each of you, perhaps to explain a little bit on Dr. King. It's asking you about a little bit to go in depth on cultural acceptability and use of technology for surveillance, especially when it comes to issues like, you mentioned about possible use of microchips and things like that. So I really want you to to say a few words about, that cultural acceptability piece, especially in LMICs where some of these technologies are not that much known. To Dr. Gibson, wonderful work, and indeed, no words to show you how much happy I am hearing all what you mentioned, all the success stories, and especially on one of the slides you mentioned about the momentum for sustainability. But I really want you to comment on that piece, specifically sustaining the gains and beyond the project period. 8 years. This is a wonderful model on rabies elimination. If what's done, what will happen. So in terms of sustaining and scaling up, I want you to comment on that piece, because most of the time projects may not do it that way. And so thanks again. Back to you, Dr. Zara.
Dr. King, Dr. Gibson, you may go ahead. Yeah.
Thank you for the question. Before I just answer that, I just want to point out something that Andy showed. I talked about barriers being governments. Andy showed you start surveillance, disease increases. Yeah. Disease hasn't increased, but it looks like it has. You have to engage governments with these surveillance programs, otherwise it just looks terrible. If people understand what's happening, okay, we've improved our surveillance and now we're seeing a true picture, that's a positive. But if you don't engage people properly, then it can be difficult because it just looks bad. Culture, absolutely, I agree with you. That's why I said that we need to talk locally and understand locals and not just take Western approaches over. Definitely one of the issues that has been seen has been when you look at ear tags, that we certainly experienced in Africa, going in and trying to put ear tags into cows. Some people see that as damaging their property. It's the same as going and kicking the door down and the front door down in their house, putting a hole in their animal and putting a tag on. And yes, putting chips in and things like that, definitely all of those things have to be approached properly, and they have to work with people. And that's where the local engagement comes. And rather than going in and saying, we're going to put a tag in your animal, we're going to identify your animal, it's going in and talking about what the benefits are and why it's being done, and taking the time to really work through those issues so that people can see the benefit. And that is going to take much longer. It takes a lot more investment of time and resources, but that's a sustainable approach, working with cultures, not against cultures. And I think if we look in the past, too often it has been, we know better, we're coming in, we're telling you what to do. That is not a sustainable picture. It does not change what's going on. Instead, you have to be, I often talk about our approaches. We're not the heroes. We often go into things thinking we're the heroes. We're not. We have to go in as the guides. but the Luke Skywalker in the story is the local person. We're the Obi-Wan Kenobi, whereas not with the Luke Skywalker kind of thing. And if we actually work with the culture and spend time and help them understand how they can do things better and how that is going to be a benefit, that's how we'll improve things. Andy.
Great, thank you. And thank you for the question, Dr. Getnet, and thank you so much for your kind words. It really does mean a lot. I think it's really interesting why rabies is such an intractable problem. And there's a huge global momentum to try and address this disease, but it's not matched by the on-the-ground district politician or state politician necessarily. And that's really, that cycle of neglect is really stimulated through the lack of surveillance data and the lack of understanding. Our staff, a story that comes to mind is our member of staff who started the Bangalore program 2 years ago, who grew up in Bangalore and started finding all these rabies cases, started going out and testing suspect cases, getting the diagnosis of rabies, seeing the map that I showed all over the city. And he grew up there, he said, I had no idea rabies was this prevalent. He had no idea it's that. So no one really knows the true picture. The epidemiological picture of rabies is this sort of simmering, grumbling, low-level endemic incidence, and it very rarely captures the headlines. When it does, it's fleeting, and so it doesn't sustain that in people's minds that this is a disease we need to address. But when you put it all together and have that data and the economic impact, the impact on people at the margins of society, it's enormous, and it's a very cost-effective problem to address, but it starts with that surveillance data. So that's why it is so critical. But the other thing with rabies is that the response to a suspect case in itself can be life-saving. It's when there's a rabid dog on the streets biting children, it's terrifying and people don't know who to turn to. And so if the government has a system that can provide a response, that is, in the public's eyes, superheroes coming to remove this dog and to protect their community. And so that response in the case of rabies can only be welcomed by the community. The only alternative is for people to shut their doors or to beat that dog to death and put themselves at risk. And so if someone from the government is coming to take that dog, to do an assessment, to remove it and get it tested, that in itself is life-saving. And then from our perspective, this is not easy to implement. If you don't have the tools that we've worked for the last 8 years to develop and provide an infrastructure, albeit flexible, to be able to adapt to the local needs, but at least a framework upon which to provide some guidance and a starting point. They haven't got to do that research and development themselves. They're provided with a tool that is built for rabies surveillance, and doesn't take long to train someone on how to do that. They can take the app into the field and they're away very quickly. And so politicians can then see results in a very short period of time, and that also helps to generate that momentum. So I think our approach is really to do this difficult R&D that perhaps doesn't make political sense, to invest heavily in something that we have an unknown outcome. We can provide these tools with a much more guaranteed chance of success for a known cost to the government, and the cost goes into their work. And we're there to provide that support and guidance and experience and examples of success. So thank you for the question.
Yeah, I think if I may just follow on a little bit, one of the really interesting things with this is when we start understanding disease better and we start controlling it better, that in itself starts to change culture. We're going back to that question about culture. It changes behaviors and how people act. So if we talk about rabies and look at that and people's responses to dogs, where you have rabies as a problem at a local level, people are scared of dogs. Now, the number of dogs that actually are carrying rabies is very, very low, but people are aware of it, and therefore dogs become a bad thing and something that people worry about and they're scared about. And that leads to how people then interact with dogs. What we've seen, where we've been successful or starting to see, where we're seeing rabies getting under control at local levels, it can completely change how people are actually responding. And there is an area I'm not going to name it because it's currently not being published, but where we've had a long ongoing program to improve rabies control, and that has led to first getting rid of rabies. That's then led to a change in response to how people see dogs, and the dogs have started to become more of a family animal, still still on the streets, but much more accepted in the community, let's say a community animal rather than a family animal. And that in turn has led for the first time this year for them starting to look to ban using dog meat for food for humans. So it's changing culture because we've actually improved and understood what's happening with disease, but that starts with surveillance and knowing what you've got. Then you're able to approach it properly, and then you're able to change behaviors. So the whole thing connects up. This very, very complex picture of everything that's involved. It's not just about controlling a disease.
Okay, thank you so much, Boz. Let me give a chance also to read a question from the participants through the Q&A box, and then I'll come back to you, Dr. Halley. Abebe Bellet Abitao is asking a question. I have seen that engaging paraprofessional as a point of intervention. Do you have any experience with it so that we can adopt the techniques? How? Otherwise, how do you think the quality of the surveillance output may be under or overestimating the issue? Probably Dr. King get this.
If we could get overestimation, I'd be quite happy. I think
Okay.
the problem is under. So I don't mind things being reported twice. I can deal with that. I think where we've got engagement with paraprofessionals, Andy's talked about some with the community officers, and you might want to expand on that. We've seen it with other areas with rabies as well. And it's about getting those people educated so they're then able to talk to the community. And what we're then seeing is the community starting to understand the disease and why it's important as well. So it does fit in. We are seeing it. We've done it in Tanzania a little bit as well. And that it just builds a better picture. Where you've got poor access to vets or poor access to doctors, if the vet or the doctor comes in once every 6 months, does a few things and leaves, the community don't know that person, so they don't trust them. They're not going to listen to them. They're not going to remember what they've said. Where we're seeing working with the paraprofessionals is actually getting real community engagement. So it is being done. Andy, you might want to comment on your community officers.
I'd agree with that. I think surveillance is all built off of those community health officers. There aren't enough vets. What we've seen is when the veterinarians try and take on the role of investigator, they don't have the time. That timely response is critical. And often the cases come at a time of day when they're busy with another disease or responsibility. So it needs someone that's full-time responsible for being in communities, responding in that timely way. And that can only be possible with paraprofessionals.
Yeah, thank you. Maybe let me give a chance to Dr. Halley.
Hi, thank you. Once again, I just want to reiterate what's been said before. Wonderful presentations, and very interested in the way you're working at the local and individual level. I think that's such a great way to do things, and including with your apps and your app development and with the officers on the ground. One question I have for you around that. To you, as you're developing your program, so obviously you're very aware of the cultures and of the need to communicate and to get input from people on the ground and who are dealing with these issues right there. Do you engage social scientists as you develop programs? Social scientists who are familiar with the ways people interact with artificial intelligence, interact with apps, interact with or how human systems work. And I think of that certainly at the local and individual level, but I also think of it in my past life. I have worked at the intersection of policy and science. And I've worked with, in the US, I've worked with policy with the US federal government and also at the state level. And I'm interested in, and that's why I'm interested in whether you work with social scientist professionals as you develop your programs.
Thank you for the question, Dr. Haley. We are increasingly trying to engage social scientists. We routinely do conduct community questionnaires, CAP surveys to try and quantify people's perceptions and their approaches and how they would like to engage with programs in different locations. I think our approach has always started from trying to engage and understand the position of government and where they currently are at, whilst also being unafraid to start something on the ground, because from that experience of implementing, as long as you're quickly iterating on your approach, which we really actively do, you very quickly learn where you're going wrong. Whereas if you spend forever kind of just trying to gauge before taking that first step, things can fail to progress. So I think our experience, our approach has always been to try and make personal connections, understand as best as we possibly can, and then get moving. When it comes to control of rabies, it's really just vaccinate dogs. And in many of these different project sites, there are different kind of reactions from communities, and we have to adjust the approach based on those responses. But the programs are all grounded in working with the local animal husbandry departments, the local medics, the local vets. And so it's perhaps not as formalized as working with social scientist professionals from the outset, but certainly an area that we're increasingly conducting research in. So there has been one publication out of GOHi just this year on that sort of side of things. So yeah, thank you for the question.
I think it's a really good question and a really good point, and I don't think we do it nearly enough. Animal health medicine doesn't have as much money as human health medicine, and that in itself makes it really difficult. I talked about the use of AI, artificial intelligence algorithms, to pick up stuff on social media. I had that idea many, many years ago, and I'm really annoyed that it's happened in human medicine before it did in animal medicine, because I just didn't have funding to be able to set it up. And I think the same thing occurs with things like social scientists. It would be great to get more people in. Where we do manage to do that quite often is with university-based projects. So where we've got universities working with us in regions, because they're able to pull on people from multiple disciplines within the university and bring those in. And I think that's a really good one. I think the other area where you can start looking at that is when you start looking at really hackathon kind of approaches to problems, and over a weekend getting a lot of people in together to talk about it and raise it up. We need to be much, much stronger and much better at it. If you've got good ideas of how we can improve that, then I'd love to hear them.
All right, we have also a question from Dr. Rafael Vieira. He started by saying, awesome talk. And the question is, what would be a good strategy to assess dog population in some Muslim countries in Africa? Although rabies is a huge threat, we still face some local problems in catch and evaluate dogs in some parts of the world. If you have any thought on that.
So we, to the point specifically about work in Muslim countries, we are developing some connections in certain African Muslim countries. The approach, I think, would start from the same position that we know the end goal is to vaccinate a high proportion of dogs on an annual basis, and we go from there and trying to find out how to do that. With regard to accessing dogs, something we've been actively researching over the recent years is the potential role of oral rabies vaccines, particularly in areas where dogs are difficult to access and are challenging to handle. And so oral rabies vaccines as a tool to supplement a foundation of parenteral vaccination is looking like it's going to be needed in certain settings. So I think it very much depends on the dog demography of the particular country. What we know is that with parenteral approaches, we can get a very long way, and that's the starting point, is really to get something going to vaccinate as many dogs that are owned as possible and to establish that culture of dog vaccination. And then where we're seeing dogs that can't be reached via parenteral approaches, adding oral vaccination to really eliminate the virus from those areas. I hope that answers the question asked. I don't know if you've got anything to add.
I think you've covered it fairly well. On animal identification, talk about new technologies coming up, and there are, but as Andy does with the app, a photo on, you vaccinate a dog and you take a photo, then there's at least a record and you can start to identify them. A lot of these dogs do look very similar, but it starts to improve things and you start to get more idea of what's being done. And it's time working with the community and understanding what the barriers are at a local level are important.
Great. Okay, maybe following up on that animal identification piece, Jambaro is asking in those countries, maybe, or those areas where animal identification is poor, is it possible to use the mobile application? Maybe Dr. Gibson?
Yeah, absolutely. So the app can help to identify dogs. You can take a photo of each dog that you vaccinate and kind of use that to validate the work that's been done remotely. We're also looking to integrate other technologies. Through the phone, you can scan a barcode. So we've used in various research projects a barcode stuck onto the vaccination certificate, and then we can scan that again at subsequent visits and see which vaccination station they visited, and then optimize the position of vaccination points based on that. We've integrated an RFID scanner so that if you microchip dogs, you can scan them and the number can directly port into the app form. So I think smartphones are so ubiquitous now. There's so much technology coming on quickly that it can easily be integrated, particularly like Alasdair was saying, some of these ear tags and NFC technologies. It's already baked into the smartphones a lot of the time, and the price of these smartphones is coming down and down, so it's very accessible from a cost efficiency perspective. But you can absolutely use it. For the most part, on our projects, we're not identifying the individual dogs. We're vaccinating as many dogs as we can on an annual basis, and so there's no specific requirement to be able to re-identify a dog year on year.
Great. Maybe let me take this chance and ask one question myself. Dr. Gibson, on your presentation, you just showed that lateral flow device. You said it's not, I think, approved, but it has some use in the surveillance process. I think it's for canine rabies. So do you have any information about its sensitivity and things like that?
It's a very hot topic that you've touched on there. So these devices, we found them to be incredibly useful in motivating veterinarians to take a sample in remote settings. The status quo is often that vets feel if they submit a sample, it may become putrefied in transit. There aren't good transport mechanisms, or it's a huge inconvenience to try and get that sample to the lab, so they just don't bother taking a sample. Whereas when you've got a patient side or a cadaver side test you can do and you get some indication, then they're more likely to go to the trouble to take that sample. From our experience, we've published one paper out of India that showed high specificity and sensitivity in field infected dog, naturally infected rabies cases. There have been other studies from elsewhere that questioned the specificity and sensitivity. So it's a very debated topic at the moment. They're not OIE approved, so they can't be used as to monitor national surveillance, for example. But there's an ongoing working group with the United Against Rabies Forum, who are the global sort of collaboration on the elimination of rabies globally, and the outcome of that working group should hopefully provide some more concrete guidance on their use. But certainly we found that the specificity in particular is very, very high. And so if a positive is found on the LFD test, that field veterinarian can be highly confident that the dog has rabies and can immediately communicate that to the community. If it's negative, the guidance is that it's inconclusive. This test has questionable sensitivity. You shouldn't communicate that until laboratory confirmation is fed back. The main thing is we don't want field veterinarians to be offering advice to people who have been exposed based on that LFD test result, because if someone's exposed, the test is negative, but actually that was a rabid dog, they tell that person they don't get PP and they die of rabies. So they have to be used with care, and I think the training around the people using them is absolutely critical.
Thank you very much. I think we will have probably a time for one quick question. Maybe let me read the one that comes through the Q&A box, and probably you can quickly reflect on it. From Kennedy Lushai, asking, one thing to note about facial recognition is that unless dogs are truly habituated or socialized and used to human contact / closeness, it can be quite difficult to take a clear enough photograph for reliable facial recognition. Now, unfortunately, in many settings where dog identification is an issue, socialization and dog-human relationship are not ideal. which is why identification is a challenge. So it seems like more of a remark, but if you have anything you can add on that, or give us your opinion on that, we will have like a couple of minutes.
I think that's where technology is improving, and it is getting easier. We can get photographs that you can get much better quality, and we currently have a piece of equipment for identifying sea lice on salmon. So a camera underwater and fish swim past, and it can take photos of the fish, identify if they've got sea lice, and identify the age of the sea lice. Now, if you can do that underwater in those conditions, I think we can do something to get facial recognition of dogs and get that, and especially if you don't just look at the face, but the whole body. Yes, some dogs aren't used to humans. That's why I mentioned the use of drones, where you can start using those to fly, and you can get pictures with those with good cameras, which are improving all the time on our phones. You know, the quality of photos I can get now is really important. So I think, yes, we're not there, but it's something we can keep on working on and moving towards. And as we get rabies more under control, then the socialization gets better when we change behaviors, and the whole thing moves together. It goes around in circles. What I am going to do, unfortunately, sorry, I'm going to cheat, and I'm going to just mention the question that's also been typed in the box, because I think that's a really important one, talking about annual boosters, and people can't afford to do that. Well, if you use high quality vaccines, they're not necessarily annual, and currently they are annual in many countries because we haven't got good surveillance and we haven't got good identification. But good quality vaccines for rabies actually last for 3 years. So if we improved that surveillance and we improved our identification, we could start moving to a picture where you only need to get those animals vaccinated every 3 years, and that's going to really reduce the price. So yes, currently, but if we do the things we've been talking about today, actually we're going to reduce the whole cost of everything. I cheated, sorry. Andy, over to you.
Just to briefly mention on the facial recognition, I think it's being applied in some settings where majority of dogs are owned, and it's slightly easier, like in Africa, where we work in Malawi, over 98% of the dogs have an owner. Where we're working in South Asia, it's much harder to get close to the dogs, but long term, the objective is to improve responsible ownership of dogs, and that's obviously a much longer time frame to try and change that culture of dog ownership. So I agree. I think facial recognition of dogs in those settings is a little way off, but like Alasdair said, there are other technologies. And also, we know we just need to vaccinate a large number of dogs. The cost of the vaccine is a very small proportion of the total cost of the campaign, even these high quality vaccines. And so having efficient, highly systemized and effective large-scale dog vaccination campaigns is the priority, and we just need to get out there and vaccinate more dogs.
Great. Thank you very much. I think on behalf of our participants and Global One Health Initiative, thank you, Dr. Gibson and Dr. King. I really appreciate your presentation. And we have very robust participation. I think people joined from Brazil, Ethiopia, Netherlands, Qatar, Iraq. So it was very robust participation. I hope to see you with another, GOHi webinar series. And we really do appreciate it. Thank you very much.
Thank you, everyone, for listening.
Thank you, everyone. Bye-bye.
If you have further questions, you can always reach out to me. I'm always happy to answer.
Thank you.